Oh, perfect. So, hello, everybody. Good evening, good morning, or good afternoon, depending where you are exactly located on the globe. My name is Helena Silman Cohen. I'm the education lead of the International Physical Therapy for Hospice, Palliative Care, Oncology, and HIV/AIDS, or for short, the IPT-HOPE. And this webinar will be recorded and uploaded to the IPT-HOPE website and will be available for everyone. So I'm very glad and honored to introduce our speakers for today. So we have 3 speakers. We have Dr. Carolina Fernandez-Lau, and she's a lecturer at the University of Granada, Spain, and a researcher at Institute for Biomedical Research. We then have Nouf Muhammad Al-Dawayan, who is a supervisor of the Physical Rehabilitation Department at King Faisal Specialist Hospital and Research Center from Saudi Arabia. And we have Maryse Ibrahim, which is a physiotherapist and a licensed lymphedema therapist working at the McGill University Hospital Center, the Lymphedema Clinic, Lymphatic Education and Research Network of Excellence. So I would like to thank, that would be great if everybody can just mute their audio. That will be great. Mute, okay, perfect. So I would like to thank the speakers for providing this presentation for us today, and I would like to hand this over to the speakers. Just one last remark. We would like to ask everybody to ask the questions at the end of the presentation, so we will give you a few minutes. So please wait to the end, and then you'll have a chance to ask questions. You can also write them on the chat. Okay, perfect. So Carolina, you can go ahead.
Okay, thank you so much. Thank you for the invitation. For me, it's an important pleasure to be here. I have to apologize for my English if I sometimes made a mistake, because this is not my main language. So today I'm going to talk about one of my lines of research, my topic of research. I hold a PhD about physical therapy, physiotherapies in breast cancer survivors, trying to explain different pain mechanism and the approach from physiotherapy to treat different side effects from the medical treatments. And now I'm going to talk a little bit about different approach for the treatment of different side effects of head and neck cancer survivors. To introduce this type of cancer, we have to know that head and neck cancer refers to different types of cancer that affect mouth, throat, or other parts of the head and neck. And most of them are classified as squamous cells carcinoma. The most important risk factors are tobacco, alcohol consumption, and they are related to the infection of human papillomavirus. And this situation is growing up in the last decades. Its prevalence is next to 5%, and this situation is raising up too in the last years. And they are diagnosed to 10 men per one woman. But this diagnosis is rising too in the last decades because of the change of lifestyle in this population. Head and neck cancer holds the spot for the 6th most common type of cancer worldwide. And in different areas, it has different incidences and prevalence, but as I said before, the tendency is changing, is growing in the last decades. The standard therapy for the treatment of this type of cancers comprise almost always radiotherapy and sometimes surgery and or chemotherapy. And this situation has raised the survivorship up to 75%, but the survivors of this illness have frequent comorbidities associated to these treatments. The most important problems that usually we find in this population are related to radiation-induced fibrosis, inflammation, impaired mouth opening, temporomandibular disorders, or other dysfunction related to the cervical region or the shoulder. As I said, radiotherapy is used to treat almost the 80% of the patients, usually combined with surgery and or chemotherapy. This could cause different tissue damage related to muscles, tendons, ligaments, skin, or even bone, causing stiffness, fibrosis, contracture, and even late tissue damage related to chronic effects that can appear a few months after the application of the treatment, and mainly due to the damage caused to the blood vessels, releasing different substances as fibrin or prostaglandins, resulting in a collagen formation and chronic inflammation that finally produce sclerosis, atrophy, or even fibrosis. And this is one of image of different situations that we can find in these patients. One of our topic of research is related with the classification of the knowledge, different population of cancer survivors, and we made a previous research in breast cancer survival where weight spread and bilateral hyperalgesia was described, and a high proportion of myofascial trigger points bilaterally set, and this was related with different pain mechanisms related to peripheral and central sensitization. After that, we started to explore this population of head and neck cancer survivors, trying to explore this peripheral and central sensitization, possibly. And we found many similar mechanisms with breast cancer survivors, maybe related to the application of very similar treatments like radiotherapy, chemotherapy, and surgery. And we found that this population has very similar pain patterns related to the area that was treated by the medical staff. As physiotherapists, we know that we have many tools to treat these different conditions related to chronic pain and dysfunction in different areas related to the cancer or to the tumor area. And we are trying to implement different multimodal programs to treat these side effects. But at the beginning, we started with an approach more focused on manual therapy, because we try to implement this this umbrella of techniques directly to the soft tissue that we said before that could be damaged. Trying to do some mobilization and applying different pressure and stretching of the connective tissue to try to restore the fluid transport, to balance the range of motion and different dysfunction related to the application of these medical treatments. And so that we conducted this study that I am going to speak about. The aim of the study was to evaluate the effects of a manual therapy protocol, specifically myofascial induction therapy, on mouth opening, temporomandibular disorders, cervical and shoulder function. And we also evaluated the effect of the protocol in the muscle strength of the upper extremities and the perceived physical fitness on this population. We conducted a randomized control trial. We invited to participate to different survivors of head and neck cancer with temporomandibular disorders, cervical or shoulder impairments related to the oncological treatments. Finally, we randomized 46 participants to an intervention group and the rest of the participants to the control or wait list group. We developed a 6-week protocol based on manual therapy session of 40 minutes with 3 sessions per week, and we made a follow-up. And finally, we had different positive results related to an improvement in the maximal mouth opening. These results were more important in the intervention group. This had an effect size of 1.5. But this situation did not reach the detectable change of 5 millimeters. So the changes were positive in the intervention group, but not had a clinically meaningful in this variable. For the temporomandibular dysfunction, we had a positive result too in the intervention group, but we did not find we found positive results in the endurance cervical muscle with an effect size of 0.72, but we did not found positive results in the hand grip strength and neither the perception of fitness. On the other hand, we had cervical positive change in the intervention group for the cervical active range of motion, and in all the movements evaluated with different effect sites from moderate to important effect sites. And these results were clinically meaningful in all the movements evaluated, assessed. And for the shoulder active range of motion, we had positive results too in the intervention group for the majority of the movements, with different effect size ranging from moderate to important effect size for the majority of the movements assessed. So we could conclude that a myofascial induction therapy protocol can improve mouth opening, temporomandibular disorders, cervical function, and shoulder function, especially in the affected shoulder, and in different movements of the unaffected shoulders, in a population of survivors of head and neck cancer. These results were clinically meaningful only in some movements of the cervical and the shoulder active range of motion, and we did not had positive effects in the shoulder all the movement of shoulder active range of motion, in the muscle strength, or in the perceived physical fitness. So future studies should perform longer follow-ups design, or even increase the sample size, or included, as I said at the beginning, different multimodal programs using, for example, therapeutic exercise or education to try to have more positive effects on different conditions related to the fitness or the physical fitness in this kind of population. So thank you. Sorry. For my mistake in the English, and thank you.
Thank you, Carolina. I think we're ready. We will move to Maurice. Caroline, as per the speaker's request, we would like to first provide the presentation, and at the end we will answer the questions. And thank you for writing it down in the chat. I will ask it at the end of the webinar. So thank you. So Noof will be the second presenter.
Hello, and good morning, good afternoon, everyone, and thank you for the opportunity to present today. It is so nice to be among people having the same interest and sharing the same concerns. When I was putting this presentation together, I was thinking of what would be a subject that all of us as people working with oncology patients are facing in terms of maybe barriers, difficulties, and some concerns. One of the things that we keep working on is developing training programs, developing education materials for patients, and spreading awareness, and putting all this together is still not really showing the results that we would like to see on the group of patients that we are serving. I work in a big facility in Saudi Arabia. I still receive patients having their breast cancer surgeries all over the world, coming to see me as a follow-up because they are primarily Saudis, and they are coming back home after their treatment journey. Most of these patients are coming complaining of more or less the same problems, physical, emotional, psychological, that were not addressed, even if they go to very high-end facilities all over the world. So I was thinking of cancer rehabilitation as a really challenging issue. So I will just take you quickly through some of the numbers so we can all be on the same page in terms of the growing problem worldwide in terms of cancer affecting high number of people around the world. The estimated number of new cases are increasing every year. Between the year 2000 and 2020, the numbers have doubled maybe and increased from 10 million to 19 million. And the projected number that these numbers are going to increase at least 5% annually. Just a quick look into the Eastern Mediterranean region, for example, the cancer incidence has increased by 46%, and this deaths by 33% between the years 2005 and 15, so 10 years period. In 2020, there were approximately 735,000 newly diagnosed cancer cases and more than 450,000 cancer-related deaths in Eastern Mediterranean region. And these figures are expected to double in 2040. So these are big numbers coming. Just again, a quick look into the Gulf region, specifically where I come from, just for you to see that these numbers are also increased among the nationals, 72% in men and 112% in women in the last 20 years, in 20 years between 98 and 17. And by 2040, the number of newly diagnosed cancer cases is predicted to be approximately 164% increased in all ages, and the numbers will be extremely high in patients age 70 and greater, which will create a big burden coming to the services. These burdens could be doubled what we see now or tripled based on the areas that we are seeing. And if I would go closely to breast cancer specifically, which is the subject that I want to speak about more, is that the incidence of breast cancer patients all around the world in 2022 were 2.3 million cases, new cases of breast cancer, and mortality of at least 670,000 deaths globally. It is the second most common cancer around the world and the first among ladies. This pushed the WHO to start to look into the burden of breast cancer by the year 2040. And this burden is expected to be very high compared to what we see nowadays. So the number of new incidents will be 40% more by 2040 and 50% more mortality by that time, which again called for a response where the Global Breast Cancer Initiative has put together strategies to work on reducing this risk by at least 2.5% every year. So to reduce at least 25% of breast cancer deaths by 2030 and around 40% by the year 2040. So all of these things would require one of the pillars that the WHO is aiming to work on is the breast cancer management, the comprehensive breast cancer management. And I guess we as rehabilitation personnel, we are one of the very important pillars of this comprehensive treatment. As we all know, the burden of breast cancer is not only physical. So we are looking into the physical burden coming from the diagnosis, all the available treatments, and every new treatment comes in, carries some of this physical burden. The emotional burden from the diagnosis, from all the treatments again that the patient would go through, psychological burden, coping with the diagnosis and coping with the treatments. We can see the high prevalence of significant distress-related symptoms, anxiety, post-traumatic stress, and depression that is found in large numbers, and a lot of studies have worked and showed that these patients are suffering from a high psychological distress. The global impact on economy due to breast cancer, again, the cost of the treatment that is expected to be doubled as we move on in the years. And what I'm just concerned about is, again, the indirect costs of cancer survivorship. That is, again, going to be doubled, and it is not really addressed even, I think, very seriously. At least I would speak about from where I come from. We are facing now a lot of difficulties, as a lot of the affected women are women of an age where they are productive, working. They are facing challenges at work, challenges at home, due to the disease itself, all the treatment and all the financial burden. Although treatment for breast cancer and all cancers is free in Saudi, again, there is an indirect cost that we are not looking very carefully to. In this Polish study, they talked about that the work loss due to cancer accounts for 0.8% of the gross domestic product of the country, which is a huge number again. I want to stress the functional decline in patients with cancer. As this functional decline is a multifactorial, sometimes we underestimate this functional decline as we concentrate more on the we concentrate more on the mental health part of the breast cancer. And this study showed that the poor physical health was reported by 24% of the cancer survivors, and the mental health, poor mental health, was reported in 10%. So mainly, breast cancer patients are facing physical difficulties that is creating partially their emotional components of the problem. So approximately 1 of 4 cancer survivors will report poor physical health, where 1 in 10 is reporting the mental health problems. I'm stressing that because we as physiotherapists, sometimes we underestimate the amount of help that we can provide for patients, even in the survivorship journey, rather than just the acute phase and post-operative and post-chemotherapy phases. So the functional problems are prevalent, and the most important also thing that oncologists or oncology clinicians are not documenting these functional problems as patients start to come into the service complaining of fatigue, complaining of other problems. These will be all pushed into that these are normal side effects of treatment, and that the patient has to deal with it by themselves. So these problems will create disability for the patient, and at the end, these disabilities are the main risk factors for the psychological distress where cancer patients are facing. Let me just go through the... So it is very well established that the physical activity, for example, had a very important role in the cancer survivorship, in reducing fatigue and reducing distress, and even as a preventative measure for some of the cancers. And we know that there are reports quantifying these exercises, but these also need to be dose response. It is a dose response relationship that we need to address a little bit more specifically for our patients. And this has been proven with a lot of meta-analysis and other published papers. The surveillance model prospective model for surveillance for breast cancer patients have talked about rehabilitation throughout the continuum of care for patients. This is a very nice model that has a multidimensional comprehensive assessment, and that would suggest treatments and interventions at the proper time for patients. Now, these models have great results when you can apply it in a setting, but it has a lot of drawbacks, or let me say barriers to it, because it would require a lot of resources going on in. It will allow proper monitoring and developing of all the treatment toxicities and appropriate referral for cancer to proper cancer providers. And this is what we really need to refer patients at the right time before it starts to be difficult on the patient and on the medical staff as well. So talking about cost effectiveness of these programs, we don't really see, is it cost effective among all services or in all countries? It could be cost effective in some countries and not in others. So it has a lot of challenges in terms of the support that you need from medical community, resources, the time. Do you have all your patients in the same location? The need for specialized healthcare providers, the need of training for the providers, for the patients, a lot of research to show that these are cost effective in your setting. So there is a new move towards the implementing the sustaining prospective surveillance rehabilitation program based on the institute. So you would provide the services based on your specific institute, addressing the individuals, the clinics, the system barriers, the processes, the policies within your system, and based on the culture as well that you are coming from and the resources available. These integrated physical therapy practices as a new comprehensive program is a little bit more specific to the system that you're working on, the resources that you have, more patient-centered. So it won't be like one size fits all for all your patients. It will give more attention to patients, more need rather than to all patients. And it will go into the idea of supporting patients that need more support. There is a big tendency. Can you have, please, your mic on mute, whoever is having the mic open? Thank you. So we are the community, medical communities, insurance companies, big facilities that is full of patients are pushing patients into self-management more, where the individual is managing their symptoms and their physical and psychological consequences with the chronic diseases themselves, rather than having somebody to support them. Self-management has a lot of good good effect, and there are a lot of studies that support self-management, but we wanted to be careful into moving to self-management where you are just leaving the patient to do things alone without proper without proper support. So it is the move towards the supported self-management, where the patient and their families will be taking care of their health care independently with a partnership of the healthcare system. So the people would feel more confident and engaged and encouraged to self-manage themselves, but with a professional supporting them and providing them with the proper resources. So not leaving the patient to get on with it, by their own. Patients need to find out more about their conditions, to learn new skills and to manage their health, to work in partner with the health team, and to choose what is it right for them. And this would require preparing the patient with the proper skills of goal setting, reflections, and self-discovery, assessing how to access the support and the knowledge, and how to problem solve their issues, and how to take an action. So they would be able to manage themselves by themselves. So we want to encourage the patient to problem solve instead of coming up with answers themselves, or sharing some of the information with other people where they cannot get the proper resource. To use their personal resource that they have, but they can share it with a healthcare provider or a professional to know if this resource is really of a benefit for them. Build on whatever they have as a knowledge, rather than just showing them that they don't really, they cannot trust themselves. They have to shift, we have to shift the power and balance between the healthcare providers and the patients themselves, and encourage them to give it a go, and to find out what can they do by themselves, and when to ask for help, for professional help. This is important because what I can see from some of the experience we have throughout the last 20 years, that given the fact that therapists are getting more specialized, patients are pushed towards managing themselves, and early discharges from the hospitals, and shorter length of stay. These are all aspects that are giving the hospitals and medical teams the KPIs that they are looking for, but we need to look carefully on the patient needs and what the patient really would require. As self-management, if it was managed the way where we leave the patients to manage themselves alone, has a lot of drawbacks, things like anxiety and uncertainty, where the patient will be feeling that they are not doing the right thing, that this might push them again to lack of motivation and discipline. Patient might just leave everything behind, as they don't really know what to do, or they are not really sure on what they are doing. The risk of injury with this category of patients, especially if they are at high risk with the advanced diseases or specific areas of cancer. The strong move toward the digitization, where patients might feel a little bit left behind, especially older patients, lower income patients, and lower income countries, patients living in remote areas, like in Saudi. We have the cancer centers are in the big cities, and a lot of patients are living in very small, very far remote areas, that they feel that they might not get the proper treatment they want. The psychological impact of the isolation, as a patient might feel that they are doing themselves everything, and they have no one to ask when they want. So it is really important to properly manage the patient and mitigate these negative effects by providing comprehensive education and treatment and training for patients and for individuals, initial training, and an ongoing support of training. These programs has to be personalized and tailored for the patient. So we don't really give the patient just a pre-set exercises that they can go and do. It has to be personalized and adaptive as well. So we change it if we need at the specific times. The frequent reassessments are very important for the referrals at the right time, before the problems start to be huge. Utilizing technology is very important, but this needs to be based again on the patient needs, requirements, availability, and either is it virtual or in-house assessment has to be figured out. Equitability for the access of the resources, where community resources can be used, and community based, for example, organizations can have a role in that. Social and emotional support by peer mentorship, support groups, and in college participations. Implementing regular monitoring and feedback for the patients is very important. Incorporating the mental health counseling services, mindfulness practices, and so on. Empowering patients with the knowledge by teaching them how to self-monitor themselves, and to encourage patients to proactively be in the community. Encouraging the team-based approaches, interdisciplinary team within the community of medical staff, and patient-centered care. Developing the education and resources for the patients as well. This was my last slide that I wanted to share with you. Then I received an email from Anne with the World Health Organization package of interventions for rehabilitation for cancer. And this was the work for the Multinational Association of Supportive Care in Cancer. And they put 13 ambitious statements. These statements, all of them were very nicely put together, and they all talk about the supportive care that these cancer patients need. And I believe that we as physiotherapists play a major role in that. Please don't be overwhelmed with these amount of interventions that all of you might think that I as a person need to do. We don't really need to have the whole staircase visible for us. We just need to take at least one step, each one of us and their specific resources, institute, just take one first step, and things will come as you move on. Thank you very much.
Thank you, wonderful. We're now waiting for Marie's to share her presentation. And so far we had really great 2 presentations.
Can you guys see my presentation?
Yes, but it's not on, if you can show only the whole slide. Perfect.
Yeah, is that working? Perfect. Okay, great. So thank you for allowing me to present today. I apologize in advance. I have a cold, so my voice I sound like Donald Duck, so I apologize. But my name is Maurice. I'm a physiotherapist and a lymphedema therapist. I'm presenting to you today from Canada, from Montreal. And I love the fact that all 3 presenters have very different presentations in oncology rehab. So mine is going to be a little bit different. I'm presenting a case study on gynecological cancers. I don't have any disclosures because I always joke and say the medication I prescribe cannot be packaged in a pill format by pharmaceutical companies. So I don't have any pharma companies that chase after me. The objectives of the presentation today is just quickly define lymphedema, go through incidents very quickly, and then I'm going to present the gynecological case related to cancer-related lymphedema, and of course the question period for everybody at the end. So what happens when there's an interruption to the lymphatic system? And so this is when we develop something called lymphedema, which is a chronic inflammatory process that develops, and it's characterized by an abnormal accumulation of protein-rich fluid accumulated in the interstitial space due to reduced lymph transport capacity. And this is the result of damage to the lymphatic vessels, the nodes, or a malformation to the lymph vessels. And so we can globally divide lymphedema into what we call primary and secondary lymphedema. So primary is when you actually are born with an abnormal lymph vessel of some sort. So whether it's the lymph vascular system just wasn't developed, so we categorize that into aplasia, hypoplasia, or hyperplasia, versus secondary, and that's secondary to something. And so Mainly, we see that due to filariasis, cancer-related treatment. It could be the actual malignancy, so the tumor compressing on the lymphatic vessel. We could see it from severe trauma, from infection, chronic venous insufficiency, and unfortunately, with obesity rising around the world, we're seeing a tremendous amount of lymphedema due to obesity. So very quickly, just secondary lymphedema. The first image is a 6-year-old boy actually in Tanzania, and he developed lymphedema from filariasis. And so that's basically a parasitic roundworm that's known as a filarial worm. And it infects, the infection occurs when the worm enters into the host or the human via a mosquito. So, unfortunately, the mosquito is always the carrier of great news around the world. And so it enters into the human lymphatics and it destroys the lymphatic vessel. Podoconiosis is slightly different, and that occurs in more tropical highland areas around the world where people are walking more barefoot, and they get a lot of exposure to irritants, especially like clay soil from volcanic origin. Trauma, this is a patient of mine who had a really bad car accident, so that led her to developing lymphedema secondary to trauma. And then, of course, the cancer-related, and this is a case of gynecological cancer. And as we know, lymphedema can develop in different areas of the body. So the upper extremity, the lower extremity, we see it in head and neck, and of course, in the breast, truncal area, and then the scrotal or genital area, depending on what has been done. And so the incidence of cancer-related lymphedema, it's a common condition that is still underappreciated, underdiagnosed, and undertreated, and very overlooked, unfortunately, still by many professionals. And the world treats lymphedema like a rare disorder, but in fact, it isn't at all. Primary lymphedema, we don't have great stats. So some of the literature will say it's 1 in every 300 births. Others will say 1,000, others will say 10,000. So, the truth probably lies somewhere in those numbers. Secondary lymphedema as well, it's hard to get pure good incidence, but we estimate that there's around 1 million in Canada, 10 million in the US, and 250 million around the world, which is really a significant number when you think about that. So when you divide developing and developed countries, in developing countries, this mainly occurs still, unfortunately, because of the parasitic infections that cause the lymphedema because of filariasis. And then we see it, of course, because of the podoconiosis. But unfortunately, cancer rates are increasing all around the world, including in developing countries. But we don't have clear data exactly from the developing countries. And in developed countries, like I've mentioned previously, we see this because mainly of cancer-related treatment, and unfortunately because of the skyrocketing numbers of obesity. So particularly for cancer-related, within all cancers, the incidence is around 15%. Again, these are very global estimates. Within breast cancer, which is where we often think about lymphedema, and that the stats can range between 18 and sometimes up to 30%. We see it in melanoma cases, upper and lower extremity, in gynecological, genitourinary, like prostate, bladder, penile cancers, sarcoma, which can be quite high in the sarcoma population, and head and neck. So the head and neck, in fact, I'm working on a recent paper looking at the incidence, and we know that the incidence is a lot more than just 4%. So that paper is going to get published very soon. So you're going to get updated information on the incidence. Now, I always find this slide fascinating because the global burden of disease outlined a list of all the different disease burdens around the world, and they're all listed: cardiovascular, cancer, et cetera, But according to the World Health Organization, if we've got 200 million lymphedema patients worldwide, according to them, they don't have a disease burden, which I find fascinating. And it's not even acknowledged a disease burden. So you can imagine how much burden this places on the patient, but we don't even acknowledge this as a problem in our population. And to date, unfortunately, we don't have a cure to lymphedema. So once the patients develop it, it becomes a chronic and progressive problem for them. So overall, we've got 5 pillars of complex lymphatic therapy, which is named in different ways in literature. So generally skincare, manual therapy is now being used a lot more than manual lymphatic drainage because it's incorporating a lot more than just MLD, as the evidence of MLD is starting to change. Compression, exercise, and of course, self-management. And so the case that I'm presenting to you today, I decided to present a gynecological case because many of us in the oncology world, we talk mainly about lymphedema with the breast cancer population, but unfortunately with the gynecological, it can be just as significant. So this is a dear patient of ours that we've been following for many, many years. She's a 76-year-old female that presented with right leg cancer-related lymphedema. So very quickly, just to give you a bit of the story here, her cancer history was that she was diagnosed with endometrial cancer in 2010. So if you do quick math, that's around 14 years ago. She was treated with total abdominal hysterectomy, bilateral salpingo-oophorectomy, and she did in fact have bilateral pelvic lymph node dissection. So 3 on the left and 7 on the right. No chemo or no radiotherapy following. She is just general medical history, so she is classified as obese, unfortunately, with a high BMI of 35. She has rheumatoid arthritis, cholesterol, diabetes, and hypothyroidism. So typical of what we comorbid conditions that we often see in our patients. Social history, she lives alone, no children. She has a fair network of friends. And at the time she worked as a full-time accountant, actually at a hospital. So intelligent woman. And physical activity, daily walks. She drives independently. She was independent with all her activities of daily living. And her lymphedema history basically started, it was triggered by a right foot cellulitis, May 2010. And of course, her symptoms started to progress. So limb heaviness, including volume, difficulty finding shoes. And she was only using a right standard stocking that was prescribed by her oncologist before she was referred to us at the lymphedema clinic. Now, with the next few slides, I do have patient images, so I would just appreciate if we can keep those images to the slides because the patient gave me permission to use it only for this presentation. So the initial volume, when she finally came to see us at the clinic, it was quite significant. So her right leg was 130% bigger than her left leg. Mind you, she did have more lymph nodes removed on the right than left, but she did in fact have bilateral lymph nodes removed. Her thigh was 63% and her calf was 68%. And she also had genital lymphedema, including suprapubic edema that we did find. The stemmer on the right leg was positive, on the left at the time was negative. And of course, her pitting, she had the positive pitting test in the entire right leg. And on the left leg, she had mild pitting just on the anterior shin. And at the time, her mobility was completely independent. She didn't need any mobility aids to walk. And how we measure is we use our measurement board and we take measurements every 10 centimeters. And every time the patient comes in, we track their volume. And then, of course, we can see over time the differences between the 2 segments of the leg. And so this is initial pictures of what she looked at. So you can, it's pretty impressive, the difference just visually between the right and the left leg. But if you've got a really good eye, you can definitely see the lymphedema developing also on the left leg, very subtly. And so what we did was she underwent CLT treatment. And so as everybody knows in treating lymphedema, so the 2 phases of the decongestion. So the first is to reduce the volume as much as possible. So she was very compliant. She came in 2 to 3 times a week, and we did multi-layer bandage to help reduce her volume. Within 4 days, she was reducing 1.5 liters of volume. So we got a really nice reduction. And then eventually, once we started to see a plateau, then we got her into different types of garments. And so within also the first phase, we got her to do some exercises and of course skincare to make sure that she doesn't develop any irritation from the bandaging, etc. And so the compression management was, we've been through a lot with this patient in terms of the types of management that we used. So we went straight into a custom garment using a flat knit garment. And we also did a lot of combinations to help her. So we had used a toe cap for her right foot, plus a custom thigh high, a class 2. We started with a class 2, and then on top of it, we would add a custom knee high because the calf was really a big problem for her even after reduction. And then at night, we were able to get her into a 4-piece Velcro device. So essentially, she would have compression at her foot, her calf, her knee, and her thigh at night. So globally, this patient was in compression pretty much 23 over 24 hours of the day. And so different types of compressions that we use, we started with a standard multi-layer compression bandaging, different types of Velcro. And over the years, we ended up using different types of night garments, including Mobiderm, where we would even add 1 layer of short stretch bandage over to add more compression at night. And we also gave her, because of the pitting edema that we noticed on the left, a custom knee-high garment on her left leg. For her genital edema, we tried different things, including different swell spots that she would wear at night with holding it up with sports shorts. And more recently, we were trying the new Mobiderm genital the shorts with the genital pad on the inside, which she would wear at night because during the day it would be very difficult for her to wear that. And so, oh dear, sorry, my pictures disappeared. I apologize for that. They didn't all show up at the same time. So essentially, just to present Madame F for the last 14 years, it's a complex case, which I'm sure many patients have also, many therapists, excuse me, have also experienced, where, you know, you see this huge fluctuation of her volume up and down, up and down, up and down, depending on how compliant she is throughout the years. And so there's different lifestyle factors that cause patients to fluctuate a lot. So aside from all the different modalities that we used, you know, once she got into retirement, it became much more harder for her to control her lymphedema because, you know, during retirement, she ended up staying more at home. She had less mobility. She gained more weight, unfortunately. And so her lymphedema progressed throughout the years. And then eventually you start to see more and more of the skin changes, despite all the efforts that we do, just because of all the lifestyle and resources available for this patient. And so just recently, at the beginning of the year, she started to show signs of dementia, which is making it a lot more difficult for her to do her ADLs independently. And don't forget, she lives alone. She doesn't have any family around her. We did get a lot of services from what we call the CLSC, which is community services that bring professionals into the patient's home to help her with the donning and doffing. So she was always been supported by professionals in the community who come in and help her put on her garments because it's quite difficult for her because of her mobility. And recently she was admitted for another cellulitis, whereby she was at the hospital for 3 weeks. And during this time, she had no compression, unfortunately, because she forgot it at home and she didn't have any family members to bring her stuff. So it got a bit complicated at the beginning of the year for her. And unfortunately, after that admission, she had progression of her leg volume. And again, this is just due to not just the recent admission, but over the last few years, because of inconsistency with compression use, weight gain, and of course, a significant decrease in her physical activity. So this is some of her recent photos compared to when we initially saw her. So you can see the stark difference between the initial photo and all the skin changes, unfortunately, that she's experiencing, the lymph cysts, that inflammatory skin changes that we see. And also to note, you can see the significant change on her left leg as well, which she would wear on and off her garment, but unfortunately not enough. So just to kind of show you the different progression, unfortunately, with patients like this, which are quite difficult to manage. And so to manage lymphedema, really, you start with the physician that provides you with the diagnosis in conjunction with the lymphedema therapist. And of course, working together with the fitter. Now, in some countries, the fitter is the lymphedema therapist. In other countries, we have fitters that are separate. But really, it's a combined effort between many professionals to find the best fit for the patient, because with her, we would try so many different options to try to maintain and control her lymphedema. You know, custom garments using Velcro on top, all kinds of different concoctions so that we can really try our best to maintain her volume. And I always love this proverb, it takes a village to raise a child. And it's a beautiful African proverb that I really believe in, obviously not just for a child, but it does take a village to treat a lymphedema patient as well. And so, you know, everybody working hard on our team, brainstorming different ways to add layers of different types of compression, which are also functional, not just for her, but also for the professionals helping her. And so raising awareness on lymphedema is really important. And this is a global awareness. It's not just within developed countries. And so we need a lot more education to be provided to our primary physicians and, of course, to our oncology team, so that they can help us diagnose the disease early and refer right away to the lymphedema therapist to avoid the leg from becoming 130% bigger from the opposite leg. And of course, more trained lymphedema therapists to help patients manage their condition, and thinking outside the box for certain cases, because they're not all going to be very straightforward cases. Better compression coverage, not just within the province that you work, not just within the individual country, but also worldwide, because I know this is a big issue in many different countries around the world. And then, of course, improving self-management tools for patients, because unfortunately, this is a chronic disease after all. And so I just want to conclude by saying that the world treats lymphedema like a rare disease, but it's not. So please don't treat it like one either. And if there's 250 million people affected by this, you know, we have to start with one patient at a time so that we can try our best to make a difference in that patient's life. And so I just want to take this opportunity to thank my incredible team that we always continue to work super hard to do our best to help our patients. And of course, we're going to see progression with complex patients no matter how much we try. I think that's unfortunately inevitable when working with lymphedema. And of course, to all my patients, and I feel very humbled when I say this, because they continue to teach me more than I feel like I ever will be able to teach them. So for everybody I've been able to work with, I thank them. And so that's the end of my presentation. So hopefully I didn't take too much time. I'm going to stop sharing the screen so that, Helena, you can come back. Oh dear, I don't know how to do this. Hang on a second.
You just need to
there you go.
close. Yep,
Yeah,
perfect.
there you go.
Perfect. Thank
Sorry
you.
about that.
Thank you very much. So thank you very much. We had really great, strong presentations, all three of them. And I think all of them were very clear on very important topics in oncology, physical therapy. And I would like to start with some questions. First of all, to thank the presenters for their presentations. I learned a lot today, and I hope that everybody else. And we would like to ask the following questions. So we're going to start with Carolina. And Jackie asked about, no, it's not Jackie. She said she thanked your presentation. It was very clear, and I agree. I think it was very clear. Diana asked about how much of a concern is carotid artery stenosis. I mean, you can answer that, please.
First of all, we did not register any adverse effect from the protocol, but I have to say that medical doctors control these kind of things before the inclusion in the study. But I think that if we suspect this kind of problem in a patient that we are treating with myofascial induction therapy directly to the cervical area, we should control the pressure directly to the front part of the neck, and maybe try to not to make an important extension of the cervical area, so control the response during the session of the patient with this kind of manual therapy approach. But I have to say that we did not have any adverse effect, and we did not register any problem with this kind of population, because at the beginning, when you are developing this kind of trials, you have to control these kind of things. So is it okay?
That's great. And are there any modifications to treatment you have found to be beneficial?
Sorry?
Do you find there any modifications to treatment that you found to be beneficial if you suspect stenosis? So you mentioned, avoiding extension, and if you see any, certain symptoms. And of course, I think it's a really valid point that we need clearance from the doctors before we're treating, and that's what you mentioned.
Yeah.
So I guess you answered that as well, unless you have any particular techniques that you're using or...
For us, the protocol, because I think somebody asked about the more specific for the protocol. We divided the protocol in different stages. One part more center in the treatment of the scar and the superficial techniques directly to the neck and the face, because the major number of the patients had an important surgery, so we had to treat these tissues. And then another part directly to the cervical or the neck region, the front part and the back part of the neck. Another one directly to the shoulder function. And finally, very important, the treatment to the intraoral techniques, because this kind of patient have trismus and impaired mouth opening. So for them, the intraoral techniques were very, very important and very effective.
Very good. Thank you.
Thank you.
Thank you. Now we're going to move to Noof. Caroline thanked you for the presentation, and also Jackie. And Jackie has a question about why are the cancer rates increasing in your area? Is there better incidence reporting or lifestyle factors such as eating habits or lack of exercise or any environmental exposures?
Yes, it is.
Answered. Yes, so you can just
It's really all of the above, as I said, and I would just stress on the better recording of cancer cases and registries that improved significantly lately, and the factor of that the population, Saudi population, is considered a younger population. We have less number of older age population. So with the fact that the population is aging, with a better medical attention, these problems are getting more. Definitely the lifestyle change into more of a sedentary lifestyle and different eating habits and eating more junk food, more processed food is really putting a lot of stress on the systems as well.
Thank you, Noof. I think, I don't know, also I live in Israel, and there's also, I think, increased rate. I mean, I think it's also related to the fact that the population is growing. So that's one effect. And I think we're seeing younger women also diagnosed with breast cancer. And we can imagine, the treatments are getting better. So those people will live with those side effects for longer, and they definitely require a good rehabilitation. And as you mentioned, like surveillance through the years. And I think also with Marie's, it was about lymphedema, but just showing her, you know, seeing the patient for a long while, I think those patients will probably need that surveillance and supervision and treatment through the years. So thank you. And now to Marie's, I don't see any questions, but so far, if there's any questions for Marie's or Carolina or Noof, this is a good time to open your camera and the audio and your microphone so we can hear you. I just want to remind everybody we recorded this webinar, and it will be uploaded on our website, the IPT-HOPE website, soon enough. So I don't see. Yes.
Julie here.
Yes.
Sorry.
Go ahead.
Just wanted to ask, are you guys found anything helping with the re-strengthening? When you look at often with breast cancer and other components, you often have the reduction in hormones that's required. A lot of the medications requiring estrogen, progesterone reductions. Are you finding anything that's helping with rebuilding those muscles or maintaining them? Because a lot of people get forced into menopause or have reduction in estrogen, which has an impact on muscle building capabilities and also on the joints. So any other supplement components that you're finding very useful?
Noof, would you like to answer that question?
I don't know really something in specific that would really help, specifically with the hormonal problem.
I mean, if I can add, if that's okay with you, I mean, we all, I think, prescribe exercise as part of our treatment. So I believe you, Noof, as well, prescribe an exercise program to your patients.
But not in terms of supplement, I meant.
Oh, supplement. Sorry. I didn't hear that. Sorry. I agree.
Yeah.
Sorry.
The only reason I ask that is because evidently at the different ages, as you're indicating for the cancer, if they're younger and having the estrogen blocked for duration of time, the ability to re-strengthen might change, because it seems to be a lot of muscle strengthening is kind of tied with our hormonal our cycles as well. So it was just kind of curious if there's anything else you found to be more effective, because when people have gone through menopause already, that's one thing, but you've got a younger population as well getting hit with cancer. And they use a lot of, you're not allowed hormone replacement therapy, or everything you're doing the opposite. You're blocking a lot of hormones. So just kind of curious if anybody else has any other research they've had on that, whether they've done it personally or know of. That would be great.
From what I see in our patient population, that they are more concerned about the bone health, where they look into vitamin D and supplements and vitamin D. But in reality, there is not a real concern, although patients are complaining from the weakness and from the reduction in their physical activity. It is not really addressed properly, even through proper exercise programs for patients, or quantified exercise or supervised exercise. But most of the people are giving just general exercises. And to me personally, I don't think it's really working, because you would see the patient coming back complaining of the same problems over and over again during their oncology visits. So I think this is something with the aging population need to be really addressed very well, very quantifiable, and based on research, I think. Great question, yeah.
Yeah, thank you.
Okay, is there any other questions about this topic? Okay, so I guess if everybody asked their questions, we would like to thank everybody again for their time and those really strong, great presentations that we heard today, that I think really filled a lot of very important topics in oncology rehabilitation. So, and everybody that joined us today, thank you very much. And we'll see you on our next webinar. We have a webinar on July 13th. This is a good time to remind everybody, so please book your calendar. July 13th. It's posted on the IPT-HOPE. It's going to be presented by Amy Dennett about exercise. So maybe, you know, this is a good place to catch up with the latest evidence, because she recently published an article about a review. I don't remember exactly the whole title, but it's a review she published recently about exercise programs worldwide. It's global. And then we'll have 2 examples of exercise programs in different countries. So I think that will be really great to hear the latest evidence, and then to see how they actually provide it in 2 different settings. So I think that will maybe also, that's a good place to ask your question again, Julie, because I'm pretty sure maybe Amy would have a better answer about your question. I think that would probably, she would probably have the best answer to your question. She knows the evidence that is out there. She's fairly knowledgeable about those things, and specifically about exercise. I don't know if everybody's familiar here with their website, the oncology exercise tool, the toolkit, which is really very helpful. So thank you again, and say goodbye for now. And I hope that everybody will join us again on July 13th. Thank you. Bye-bye.
Thank you, everyone. Have a great rest of your day.
Bye.
Thank you. Bye.
Thank you, ladies.
Bye. 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 Bye,
Bye.
Carolina. Bye, Noof. Bye, Maurice. Thank you.
Bye. Thank you.